patients in Canada, oftentimes, increasingly, first line now will include Revlimid, either for transplant-ineligible patients until progression or in transplant-eligible patients post-transplants and maintenance. After that, typically in Canada, the switch would be to a proteasome inhibitor-based treatment. And then third line funded would typically be pomalidomide. And then beyond that would be some of the newer agents such as carfilzomib or potentially others. My own practice would include more clinical trial, but that for a patient outside of a clinical trial, that would align with my practice. And PI-based treatment that we might use second line would typically include cyclophosphamide, so a Cybor-D regimen. And pomalidomide in Canada, third line, typically would be combined with cyclophosphamide as well to enhance efficacy. So OPTIMISMM trial enrolled patients who had previously been treated 1 to 3 prior lines, and I think of particular interest are those patients who had lenalidomide and then moved on to second line. All of the patients had experienced lenalidomide, and over 90% were lenalidomide refractory, which is unique to this trial. So the trial randomized patients, about 550 patients, to either Velcade and Dex or pomalidomide Velcade and Dex, 1-to-1. The primary endpoint of the OPTIMISMM trial was PFS, and the primary goal was met with pomalidomide Velcade Dex showing a statistically improved progression-free survival versus Velcade Dex. Absolute values, median, were approximately 11 months and 7 months. And then subgroup analysis in this trial is going to be very interesting. So far what's been shown mainly is those patients who had 1 prior line, basically a Revlimid-based first line, which relates to the Canadian practice. And in those patients, the pomalidomide Velcade Dex was particularly efficacious with about 20 months of PFS versus about 11. Both were relatively well tolerated, and I don't think there was anything unexpected. So there were some thrombotic events in the pomalidomide Velcade Dex arm, but again, not out of keeping with what might be expected. All patients did receive aspirin as prophylaxis in that arm. The impact to Canadian practice for PVD versus VD is that in our practice, increasingly patients are treated with lenalidomide until progression. So that is one of the arms of this trial, or sort of one of the subpopulations in this trial. And in terms of our practice, this would be a demonstration that the PVD is a good second-line option. So I think it does relate to our practice. It is potentially doable, although not funded currently in Canada. Our typical practice would be POM Cyclodex, and it's not clear how that might compare to POM Velcade Dex. Currently, pomalidomide is typically used third line or beyond, so I think it is a good agent second line, as demonstrated in this trial. May be particularly useful for those patients post-transplant relapsing from maintenance lenalidomide.